Start. Okay. Well, good morning, everyone, and thanks for joining us today. I would first like to welcome all our, distinguished panels here in our session about how COVID-19 impacted universal health coverage. We have Oliver Groen, CEO of International Network of Health Promoting Hospitals and Health Services, Otmar Koliber, Secretary General of World Medical Association, and Howard Catton, CEO of International Council of Nurses, Karsten Angel, CEO of International Society for Quality in Healthcare, Bettina, Borisch, CEO of World Federation of Public Health Associations, Cary Adams, CEO of Union for International Cancer Control, and Neef Lennox Chugani, CEO of International Foundation for Integrated Care. Please welcome them all. I know from all your busy, responsibilities and works, you've made the effort and time to come here. So we are really, really happy to have you. You're extremely important partners to IHF, and this is an amazing occasion for all of us to know more about your organizations and, talk more about the universal health coverage. I am Dr. Tahlak, for people who don't know me, CEO of Latifa Hospital. It's a women and children hospital in Dubai, under Dubai Health Authority, UAE, and was the treasurer, and I guess still the treasurer till today, for IHF, and becoming the president designate for the next coming 2 years. Universal health coverage. I guess the three goals goes in the name, U being universal for all, health, it's quality health when needed, where needed, and coverage, more importantly, without any financial hardship. And I think, the International Committee decided long ago that they wanted this on the agendas, and it's in the SDGs. And countries have been trying hard really to reach and be able to have the universal health coverage in their countries, so no person goes unattended in their health care. But we also know that half of the world population do not have access today to health care. More than 100 million fall into extreme poverty and are not able to access care. And more than 800 million spend 10% or more of their household income on care. WHO, as a strategic priority, put a goal that 1 billion people should benefit from universal health coverage by 2023. That's in a year or 2 years' time. Now, for almost 2 years, we have all been through this with COVID and the pandemic, and it has really affected how the progress has been on universal health coverage in different places. Maybe there were challenges even before, but probably with COVID, the impact has been even more. It has brought out long, ignored global health risks. It has also showed the inadequacy in health systems and gaps in social protection. It has also exposed inconsistencies in implementation. I think what COVID did really, we moved to more treatment, although health is not only treatment, it goes from the whole panel of promotion, prevention, treatment, and palliative care. I would just tell a little bit about Dubai from an Emirates perspective, and then we will move on. We will have each of you introduce yourself, talk about your organization for 5 minutes, and then we will go for the questions. So in Emirates of Dubai in 2013, a mandate was there and a law to actually implement health insurance for all, for both residents of Dubai and for the citizens. And this insurance was mandated by law. Insurance companies were licensed to offer basic coverage to all with a minimum premium. And the adherence to the law was actually monitored, and it was integrated with the immigration authority, so linked to the residency and to the visas that were issued. It was also further reinforced by electronic registry, where people were all, with their health coverage were registered in that, not only from a demographic perspective, but also looking into where were the gaps and to fulfill in healthcare and services needed. So this big data was used to shape the policies and strategies to improve universal health coverage. During COVID, I believe, we all went through the same challenges. We did some price regulation, especially when it came to testing across the city. Insurance coverage, although most insurances do not cover pandemics, it was mandated in Emirates of Dubai to do that. And whether network related or not, they had to cover. Elective surgeries that were postponed, the approval meant that it wasn't as routine. It was allowed for 30 days beyond the opening of the facilities. We had to close the facilities at some point, which especially in wave 1. Expediting claims processing and other things instead of the usual 45 days, it meant immediately to help the healthcare providers. Mostly policies for telemedicine and home services were actually developed and were integrated in insurance schemes as part of the coverage. This is really, in a brief, a city perspective, but I think what we'd like to hear today is from a very important NGO, global NGO's perspective. So I would like to start with Oliver Groen, CEO of International Network of Health Promoting Hospitals and Health Services, to introduce himself and the organization. Please.
Well, thank you very much. The International Network of Health Promoting Hospitals and Health Services was set up about 30 years ago by the World Health Organization, following the publication of the Ottawa Charter, first global document on health promotion, which as one of the 5 action areas called for a reorientation of health services. And that reorientation meant that despite the medical advances at that time, there was a widespread belief that we need to put more emphasis on humanity, patient-centeredness, staff working conditions, and also the community impact of hospitals. I've seen many hospitals, very advanced hospitals in developed countries, which were located in areas where you have maternal mortality rates that are at the level of a developing country. So there's a gap between what the hospital is doing in the community and the community it's serving. So the key motivation of our network is to focus on health gain. What can health services contribute to improving health gain? And an example of that is elective hip surgery. What is the point of undergoing elective hip surgery if the operation is successful, but 6 months after the surgery you're still in pain and immobile? So there's something wrong in the way services are planned, organized, and executed, where there's a lack of a focus on health gain. So health promotion always has difficulties to compete with medical technologies and sophisticated therapies. But we believe health promotion is not the sugar on the cake, it's actually in the cake. It needs to be in the cake, otherwise the cake isn't good. So when it comes to the pandemic, given that health promotion has to compete or had to compete with many other urgent needs, we know that a lot of therapies and visits were cancelled. That refers to screening, primary, secondary, and tertiary prevention, and health promotion. A lot of these services and appointments, activities were reduced or cancelled. And particularly if you think about health promotion, what it really means, it has a very strong communication component, motivational counseling, therapy, oral communication, explaining things. All these are integral to health promotion and made very difficult during the pandemic. Now, if you think about the epidemiological profile and patterns of disease in developed countries, we know that about 60% of the adult population has a chronic condition, lives with a chronic condition. We know that about 40% of the adult population has 2 or more chronic conditions. And if a lot of those central interventions, health promotion, health education, were cancelled or postponed, this will have an implication in the future. So I think where we are now is we're probably observing a receding shoreline in tranquility and, well, relative tranquility, but there might actually be a tsunami of chronic disease emerging in the next couple of years. And therefore we believe that health promotion needs to be set very highly on the agenda. It needs to be integral to what health services are doing, and needs to reflect a much higher priority in the healthcare system. Thank you.
Thank you, Oliver. We'll move to Ottomer Kloiber, Secretary General of World Medical Association, to hear from you.
Thank you, Madam Chair. A few words about the World Medical Association. Is one of the younger professional organizations founded in 1947, following a preceding organization which then was assembled in World War II. And the World Medical Association was founded on the basis of the findings of abuse of medicine during World War II, especially in my own country, in Nazi Germany at that time. And since then, the organization is very much concerned and working as a global platform to develop medical ethics, the deontology of medicines, the rules for the practice. Of course, this never has been standing alone. It always has been seen in a context of our social environment from the very beginning. And so working on what we call Socio-Medical Affairs is a second arm of our work that we have been following since the beginning of the association. That nowadays includes a lot of ramifications, reaching into education, where we provide education in niches, like for instance we did a course on prison medicine, but we also did a course on multi-drug resistant tuberculosis when there was no educational material for this. And many other things where we started relatively early, like for instance antimicrobial resistance about some 25 years ago to work on. The World Medical Association nowadays unfortunately has to deal with a lot of human rights cases that has become more and more prevalent in our work, which I think is pretty sad. But we also have done a number of educational series on emergency preparedness, especially about 10-15 years ago, when we were triggered not only by some natural events, you remember the tsunami in 2014, but also the bird flu and the threat of a pandemic of flu, which we saw at that time. Some of our members have reacted quite nicely with that, and we have seen development in the physician societies towards better preparedness, especially for pandemics, but also for other emergencies. Japan is a very good example, but many of the other East Asian countries also did a lot of work in being better prepared. And I think last year we have seen the effects of that when the COVID-19 hit us all. For us, coming to the core topic of this session, universal health coverage is probably the most important strategic development that we have seen in global health, and especially from WHO. And we also think it's the most meaningful approach that ever has been made there. That doesn't say that there have been campaigns and technical work of the World Health Organization that has been crucially important and very successful. But as an overarching concept, universal health coverage for us is the core concept of developing healthcare systems, because it encompasses all areas and it does not fall back in the siloed approach which we have seen before in global health and also in the work of WHO, of course. Now, you may say that is not enough. Yes, that's true. We all know that the social determinants of health are extremely crucial for the development of health in a society and individuals. And that, of course, is not covered by universal health coverage, but nevertheless, universal health coverage is the key element to provide equity within healthcare systems, and therefore we are strongly behind this concept and promote this concept with our work. During the pandemic, for us, it has been extremely important to see that the economic approaches to healthcare, which we have seen over the past 3 decades, more or less have failed. What we have seen is that we have healthcare systems which were built after examples from general industry, lean production, very fragile supply chains, just-in-time deliveries, all that stuff you have seen in the economic development since the 1980s, which are more directed towards shareholder value than to stakeholder value. And of course, in healthcare, we have to find out that healthcare is not about just-in-time. Healthcare is about just-in-case. And to that extent, we failed dramatically over the past 2 years because we were not prepared. At least most of our countries were not prepared. So we have seen certainly a very dramatic development, which to a large extent we thought would have been preventable if measures had been taken, if preparation had been taken, if supply chains had been made more resilient and better. Something which we have seen before and have monitored and have warned against, especially when it comes to drug supplies over the past 10 years. But unfortunately, so far nothing had changed. We hope very much, and we hope we come back in this discussion about universal health coverage and COVID-19, that there are some learnings which we can take away and change our systems so that they become more resilient. And with a better surge capacity for pandemics, but also, and more important, to prevent the spread of epidemics not to become a pandemic in the future. I think that is something which we should have a focus on in looking on what we have to change in our healthcare systems and in our behavior. And again, universal health coverage is certainly a very strong instrument to help that development and that prevention, which means that universal health coverage stays very high on the agenda, actually on the top of the agenda for the development of our healthcare systems, and we would like to see more efforts and more means being put on that in order to reach this aim in more countries than we have right now. Thank you very much.
Thank you. Couldn't agree more, Ottomar. Thank you. We move on to Bettina Borisch, the CEO of World Federation of Public Health Associations. And I think, Bettina, I'm sure you know your association with this pandemic would have probably, you have a lot to say, I'm sure.
Thank you very much. My name is Bettina Borisch. Yes, I'm the CEO of the World Federation of Public Health Associations, and I'm also a professor of global public health at the University of Geneva. If I would start the classical way, I would say the World Federation of Public Health Association is the only worldwide society that represents the interests of public health worldwide. I would say we cover over 5 million public health professionals. But I would like to turn to my colleagues here on the panel, because we are all public health people. All of us here in the room, all of us on the panel, we want and we work with our strengths, our competencies for the health of populations. Our chairwoman delivers healthy babies from healthy women. And that's what she's really passionate about, I think. Sure. And in the cancer field, Cary is helping people who have an illness to live it as healthy as possible. And the nurses and the doctors, they all are there. So public health is all of us. The World Federation of Public Health Association together with the World Health Organization, has created what we call the Global Charter for the Public's Health. And we say public's health, because health is an issue of all of us, and especially of us working there. And like my neighbor here said, health and promoting health and protecting health is what we finally all do, but with different focus. So I think being in this broad field that is all dear to us, the question about universal health coverage and COVID came in. What you said about universal health coverage is exactly that. We have it because health should be a human right. It should be accessible to all without financial hardship. UHC is about equity, and if we talk about equity and human rights, then we talk about politics. So universal health coverage, we know all OECD countries except one do have a system that is universal health coverage, but universal health coverage is a system, and it comes in very different shapes all around the places where we do have universal health coverage. So COVID showed us the predetermined breaking points, the fragility, and magnified the underlying inequities. So if there are predetermined breaking points, then the system wasn't solid and not crisis-proof. So we have to look at good political leadership, because people think that we are battling a virus. Indeed, it is a medical problem. But look at the Global Health Security Index that shows what countries are best prepared for a health security issue. It ranks US and UK first and second, respectively. And what happened, even though these countries have very, very keen public health research and competencies in-house, but I think they had the wrong political leadership when the pandemic arrived. And so we are talking about a whole social health and security system that is very much depending on political issues. And universal health coverage shows us that health is a political issue, and it's a political decision. So the COVID for us at the World Federation came into a moment in time where we were already saying, we as people of this world want to live all together in peace and good health. We have to make the right decisions, and the right decisions in time. So we have to collaborate, we have to work together, and we need more collaboration, as we will probably be doing as NGOs more quickly than governments. Governments do have some slow-moving procedures, whereas I would say the liberty of us, the NGOs, is to go quicker into collaboration and to see our common goal, health for the population of the world. So our World Federation focused again and even more strongly on this social problem. And you know that in public health, parts is science and is data and is epidemiology. But epidemiologists told me, look, epidemiology is like driving a car by looking into the rear mirror. Epidemiology will tell you what has happened. But what we have to do is we have to plan forward. And I'm very happy we're here together, all together, because we have to plan forward for the next pandemic, for the next crisis. And we are very much working now in November is a special session of WHO about a possible pandemic treaty, about the ways we all can be better prepared, and this is focus of our work. So we are working on the units of decision and not so much about all the factors that are splitting us. Thank you.
Thank you, Bettina. We will move on to Howard Catton, CEO of International Council of Nurses. I'm sure Howard, can tell us a lot about, your organization and how it was affected during the pandemic.
Thank you, Dr. Muna. Good morning, everyone. Delighted to be here. I'm a nurse and I'm the CEO of the International Council of Nurses. We're the international federation of more than 130 national nursing associations from right the way around the world. If ObMar is the youngest professional association, I think that we're one of the oldest in 1899 when we were formed. I just want to give a shout out and a thanks to Ron and to IHF for the focus on nursing this morning and on yesterday. Ron and I have also worked, we had our Congress, 5,500 nurses from around the world last week, and we did some reciprocal sessions on nursing leadership that some of IHF's colleagues participated in, and the nurses, I think, are here in a few numbers over these few days, which is great. We were asked to bring some numbers, so I'm going to share some numbers with you. There are about 28 million nurses worldwide. You would have heard this morning that we went into this pandemic 6 million nurses short. WHO, ICN report 22% short we went into the pandemic with. There are about 4 or 5 million nurses due to retire in the next 5 to 10 years. Ageing nursing population mainly in Europe and in North America. We've done some work to look at the effect of the pandemic on nurses. We've called it the COVID effect, the intensity of work, mental health, infection rates, all of the things that you're aware of. We think that could add another 2 million. So we're up to about 12, 13 million nurses, half the global nursing workforce who we could be looking at have to replace over the next few years. If we don't do that, we're not going to have any universal health care coverage. In fact, our health services, I think, are going to go backwards in very many places. And what I was interested that one of your colleagues did a straw poll in the auditorium yesterday about the percentage of attrition, the attrition percentages that CEOs thought might be coming down the tracks across the whole health workforce. The work that ICN has done has been based on assumptions of losing somewhere between 5 and 10%. The majority of your CEO colleagues put their hands up to 10 to 15%. So yeah. It could be even more significant than that. So clearly there is a massive need to invest in education and training of the health care workforce. We agree with the OECD. It looks like it's going to put another 1% on GDP. This is probably the least sexy of all of the health policy topics that we talk about, but it goes to the root of how we went into this pandemic 6 million short and how we're going to increase the health workforce. What are the workforce planning assumptions that are being undertaken in the decisions in country? What are countries' assumptions about their supply line, the numbers coming through? Are they working on the basis of hitting self-sufficiency, or are they deliberately looking at going below self-sufficiency because they're going to recruit overseas? When they look at those numbers, how are they funding those numbers come in? Where is the faculty coming from? Where are the clinical placements for new graduates and entrants coming through from? I think we need to pay huge amount more attention to workforce planning than we currently are. The lack of that workforce planning, what are we seeing right now? We are now seeing an increase in recruitment, particularly from Europe and North America, from middle and low income countries. There was a really big warning that you heard this morning. I heard this morning, we were aware of this. The Filipino nurse who joined the nursing session talked about 250,000 nursing shortage currently in the Philippines. The Philippines and India have been suppliers of nursing to the world. That's where the big numbers have come from. Philippines have got shortages. The ambitions around UHC for Modi care in India, I think, also will constrain the numbers that come in from that country. And the places that some of the high-income countries are recruiting from, Europe, North America, ratios of 80 to 90 nurses per 100,000 population, are recruiting from countries where that ratio might be 10 or 20 nurses per population. It's going to undermine and destabilise those healthcare systems. That whole piece around workforce planning in the future doesn't, of course, solve the whole and the problem that we're in now. That's a 3, 4, 5 or even a 7 or 8 year issue for our medical colleagues. So what do we need to do? Retain, 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 retain. Absolutely 100%. Bit controversial here. I hear a lot about retention and the sorts of solutions for retention. We need to do more resilience training, mindfulness, teamwork support. Those are all really important things, and I'm not undermining them in any way, shape or form, but it's symptoms, it's not cause. Those attrition rates that we're looking at now, because we went in 6 million short, I absolutely believe that those attrition rates are higher than what they would have been if we had have gone in without a shortage of nurses. Because if you start 6 million down and you have the intensity of one pandemic, it takes you out when you've already been working very stretched. And then you hit another surge and another surge and another surge. The cumulative effect, none of us are superhuman, means that our current workforce are leaving at a faster rate than if we had gone in with a fully maxed up number of nurses that we needed. So what sort of things do we need to do? Flexibility is a big one. I'm with Otmar on this, all the just-in-time stuff and the organisational needs around individuals. I think you need to be taking much more attention of what the needs of your health workforce are. Flexibility, carers, leave, dependence issues. You need to be listening to the workforce for what their needs are, but also listening to the workforce in a way which they know that their voice is valued and respected. Great that people say, leaders say, we walk the wards, our door is always open. I think we need but more robust mechanisms than that. How often are you talking about feedback from the front line at the board meeting? How does the staff feedback fit into the organisation's quality improvement networks? I have to also talk about pay. We did some work to look at nurses' pay around the world after the global downturn. We saw the chill effect that had, flatlining on pay rates around the world from like 2007-8 to 12-13. OECD have just released some work to say that that's continued from 13-14 to 19 as well. The US and France up until 19, like the last 10 years, their pay rates in real terms have been flatlining. The UK, in real terms, nurses' pay has actually gone down. Solution, and I'll just finish on this a more of an upbeat note, I hope, in terms of a solution. You've heard a lot about advanced nursing roles, specialist nurses roles. I believe they are absolutely a big part of the solution to dealing with ageing populations, chronic diseases as well. There's a very strong evidence base about the effectiveness and value of those roles. Latest OEC data shows that the country which has got the most advanced practice nurses is the US at 6.5% of its nursing population. At most countries, it's less than 2%. Now that says something as well about career structures for nurses and ambitions to move on. But what would you expect that advanced practice piece of the pyramid to be? Perhaps 20% or something. It's not. Also something about how we need to get rid of the regulations that are in the way and impeding people of working to the top of their license to maximise their contributions. Thanks very much.
Thank you, Howard. We move on to Karsten Angel from ESQA, and the floor is yours.
Thank you. My name is Karsten Angel, and I'm the CEO of ISQA, the International Society for Quality in Healthcare. We are a member-based organization. We have both individual members and institutional members. Our institutional members are, for a large part, accreditation bodies, but there are many other institutional members as well. Most of them institutions who in some way support, facilitate quality and safety development, but also some healthcare provider institutions. Our individual members, most if not most of them would have a health professional background, but again, most would currently be working either in research or as some kind of quality safety consultants, facilitators. We operate, our mission could be described under the headline Knowledge Network Voice. We collect knowledge through our networks, we make it available through our networks, and we give voice to members who have knowledge they want to share through our networks. And our networks includes our members, of course, but we also have a cohort of experts, and we have established an academy of quality and safety where we have gathered some of the world-leading experts in the field. And we have a lot of partnerships, including a strong partnership and long-lasting partnership with the International Hospital Federation. What kind of knowledge is it then that we are brokering? Well, it's knowledge about how to achieve quality and safety. It's very important to us that the knowledge we provide is based on the best possible evidence. It's a knowledge about what to, and it's a knowledge about how to. And I think that knowledge has the power to drive changes, the kind of political changes we have heard about, by making it visible what we could do and how we could do it. And that's an important part of our mission. We promote this mission in a number of ways. Among the more traditional ways are that we have an annual conference, we have 2 scientific peer-reviewed journals, but we also have established some education programs where we try to reach people around the world, but in particular this has also been taken well up in low and middle income countries by providing small packages of lessons where you can spend 6 or 8 hours and be well informed by world-leading experts on the field you are digging into. And we also actually believe that accreditation, external evaluation, can be more than just control of whether you comply with rules. It can also be leveraged as an important way of spreading knowledge, spreading good practice, and spreading ideas. So, what has been the impact of COVID? Well, obviously it has impacted the way in which we operate, but more interesting, it has also set some new agendas for what kind of knowledge is it that we would like to promote. We will have a specific focus in the coming years about resilience. How do we create resilience? How do we recognize resilience? How do we promote resilience? How do we assess resilience? Obviously, there are also new delivery models, things like telehealth, that has a huge impact on healthcare, and we also would like to emphasize the systems perspective. Hospitals are important and will continue to be important, but hospitals are embedded in a larger system which also includes primary care, and how do we make all these components work together? And COVID has also clearly demonstrated that health is not just a function of healthcare systems, but it's also a function of public health measures, and what we do have impact on health, but also have large impact of other kinds of society. So the network perspective is a very important one. Then there's sustainability. I mean, we are in one crisis now, the next crisis might be ahead of us. We will explore ways to address this as well. And finally, there is person-centeredness. Person-centeredness has been challenged by the ways we have had to deliver healthcare during the last years, but it is and will remain a very important and very high on the agenda. We have established relations between researchers in the field and representatives of persons with lived experience of being patients and relatives, and are thus generating and leveraging both impetus for actions and knowledge on how to do. So, to finalize, from a practical point of view, if you had a research question of some kind related to quality and safety, we would be able to find probably somewhere in our network someone who maybe knew the answer, or would be able to generate a review of literature to clarify what the answer is, or perhaps to initiate a research project in cooperation with some of you to illuminate and increase our knowledge about this question. Thank you.
Thank you, Karsten. We move on to Neve Lennox Chogani, CEO of International Foundation for Integrated Care. Please.
Thank you, Muna, and thank you everybody for being here this morning. In particular, thanks to the International Hospital Federation for inviting the International Foundation for Integrated Care to be part of this panel. I have to say, I've heard the word integration time and time again throughout many sessions that I've been at the last day or so. The Foundation is probably one of the younger organizations on this panel. We've only been around for 10 years, which probably mirrors the experience of integration and integration as a concept within our health and care systems. We're a movement for change, so we're not a membership organization. We're open to anybody who wants to come and join us, who believes that integrated care is a design principle that is fundamental to delivering on the ambition of universal health coverage. Our vision is for health systems or health and care systems where everybody who needs care experiences that as joined up and seamless, and meeting the outcomes that they and the community they live in want. And that community element is really important, and I think echoes some of what Benito was saying as well about the importance of us seeing prevention and public health as central to the health and well-being of our communities. If we look at, as the Foundation, at the impact of COVID on the systems that we've been working with, they're probably twofold. So one is that we, as has been said in many sessions, the fragility of our health and care systems, that many of which evolved and developed in the 20th century in response to the health and care needs of the populations then, has been exposed as not fit for purpose in the 21st century, and particularly in the context of the pandemic that we've just been through, for all of the reasons that my fellow panelists have elucidated. But what we have also seen is a lot of system innovation in the face of the pandemic. So we've seen a digital first approach being taken by many systems. We've accelerated digital in healthcare for the first time ever. I don't think anyone can say now that health is the laggard in digital that people have been saying for such a long time. But also we've seen initiatives like Hospital at Home, which I think have proven particularly beneficial through the COVID pandemic. One of the areas that we have had less influence than we would like is in the role of hospitals in promoting and delivering integrated care. A lot of our engagement has been with community services, with social care, with primary care, historically. Less so with hospitals. And that also is something that we have seen change through the pandemic. We're just about to publish a paper with the Children's Hospital of Queensland, where they have shared their experience of what it is to be an anchor institution within a health and care system at state level through the pandemic. And the kind of work they did, the strategy they undertook to become that anchor institution within their community, recognizing their really important place and their role in the pandemic, was to operationalize what they've termed a power commitment, if you like. So they talked about a continuum of collaboration. So it starts with networking, where as a hospital you share information with your system partners. That moves into coordination, where you start to share activities. And that moves further into cooperation, where you start to share resources as well. When you're moving now into collaboration, you're actually talking about sharing benefits. One of the conversations that Frank Tracy, the CEO of the hospital, and I talked about when we were developing this paper was actually, for a lot of systems, those first 3 levels are actually relatively easy because they don't require giving too much away. But actually, when you get into sharing benefits, it's clear that a lot of our systems are not really set up yet for that to happen. And if we're going to make universal health coverage and integrated care as a mechanism for doing that work, we need to move into that place. So those are my thoughts initially on this subject, and thank you for listening.
Thank you, Niamh. Cary Adams, CEO of Union for International Cancer Control. Please, the stage is yours.
Thank you very much. I'm conscious that I'm very close to the steps here, so I'm a fall over, blame the organisers. I didn't expect here to come here and break my neck. So I hope you can all hear me. I have to declare my age. 1933 we are, okay, so we're in the middle somewhere of everyone here. And we were set up in Paris, Union for International Cancer Control, and to share and collaborate information and research on cancer as it emerged around the world. But now in Geneva and working in formal relations with the World Health Organization. So we're 1,200 organizational members in 173 countries, and we're the umbrella for those organizations. And the key principles of collaboration, sharing information, working together, making knowledge have power around the world is still very much part of what we do. So we're based in Geneva because we work with the World Health Organization and other organizations on advocacy to make sure that cancer and the other NCDs on the global health agenda, which they weren't in the first part of this century. It was all about the communicable diseases, but the world has changed slightly since 2011. We work on capacity building, working with our members to help them do a better job tomorrow compared to what they're doing today. And that features particularly looking at the leadership challenges of running organizations in the health sector, more than doing the technical training, which is left to other organizations around the world. And we do convening. We bring together our own congress, and we have a World Cancer Leaders Summit, which I'll talk about in a moment. The fourth thing we do, which is not something that we necessarily plan to do, but when we see an opportunity to fill a gap in the health approach to particular issues, we are very open to create new organizations and collaborations. So in the 12 years that I've been around, we've created an International Cancer Control Partnership, which advises national governments on how to write a national cancer control plan and put in place registries. We've created the NCD Alliance, which some people may have heard of, which I still sit on the board of, which brings together diabetes, heart disease, lung disease, and cancer to collectively work on the common risk factors and the common challenges, including the implementation of universal health coverage. A couple of years ago, we launched a City Cancer Challenge Foundation, which works with cities in lower middle income countries over 1 million population to improve the coordination of cancer treatment and care across those cities. Been very effective the last few years. And one which was a bit unusual when we decided to go for it was we created a law centre which helps the lawyers in governments work together collectively and virtually around the world to put in place the laws which address many of the risk factors which cause cancer and the NCDs, like tobacco control. And that was important because the tobacco industry, for example, is very well resourced, employs all the best lawyers to stop all the laws going through government by government on increasing taxes and plain packaging. So I used to use it as an example of where I feel I ticked the box on being a global public health ambassador. So thank you, Bettina. I like joining your gang. That's great. If I go back to the World Cancer Leaders Summit, the last 2 summits have been on universal health coverage. They run every 2 years. We bring the top 400 or so or individuals who run cancer organizations around the world together to discuss a topic which is important, we think is important to cancer control. Cancer control being prevention, early detection, treatment and care. The UHC topic was done in 2019, and this one 2 weeks ago was actually on equity, so again linked. Things that are important to the cancer control specialists and leaders of the world, and we are totally behind universal health coverage. We may sit in the silo of cancer, but as I've shown through the organizations we've established, we know the power of collaboration. We know that collectively we're addressing the same issue, which is the health of the world. Now, I would say that COVID has challenged the cancer community significantly and under 3 dimensions. Dimension 1 is, and to some extent we understand the situation. There were resources were taken away from cancer treatment and care and put into COVID treatment and care. Now, there was cancellation of treatment around the world. In some places, they reckon it's going to take 3 years to catch up. There was also the cancellation of screenings, the ability to pick up early enough and treat early enough things like colon cancer, breast cancer, cervical cancer. And that was general around the world because of the challenges of COVID. So we saw a health systems response, which was actually a negative for cancer treatment and care and the early detection of cancer. Then there was the individual response, the response of individuals who maybe thought they had a problem but weren't prepared to go into the health system for the fear of getting COVID, as I think it's been mentioned before. And so we know we've got a massive backlog of cancers that are progressing through stage 1, stage 2, stage 3. And of course, the further they go through their stages, the more complicated the treatment, the more challenging the treatment, and unfortunately, unsuccessful the treatment. So we've got a backlog, and we've got the big cancer catch-up, which we need to do to focus on in the next few years as we build back after the pandemic. And the last one, which I think is important, many of our members are patient societies, patient groups, and they're cancer societies. And yes, they do sort of sit outside the health system, but they're integral to the journey of a cancer patient through the health system. They do a lot of work with governments, often paid by governments, to do education, to do health promotion, to do all sorts of things. And yet these organisations invariably are supported by gala dinners, by runs, by walks, and all these sort of things. And our research recently suggested that over half of all cancer organisations around the world have seen a 50% drop in their annual income. And they're having to cut back on services and cut back on the number of people they have and the programs they run. And this is going to take a long time to recover because they were integral to working with patients as they went through the challenge of their diagnosis or getting their diagnosis in the first place. I will conclude with some silver linings because I think there are silver linings in here, but we have to make the most of them. The first one is we become a generation conscious of, and I can see all of the masks in front of me, of the value of prevention, of understanding risk factors. The question is, how can we bring that into the normal world when we're talking about tobacco use, obesity, and things like that? How can we take that generation of conscious of personal behavior affecting their risk of being ill or developing a disease? The second silver lining is that we've argued as a community for years and years and years that health is a whole of government issue. And it's sat in the health minister space, which is not often a junior minister role, one to get a promotion to a bigger job, and is often starved of cash. Now, for the first time, we've had in practice, it's a whole of government issue. It affects education, it affects trade, it affects agriculture, it affects the finances and the economy and the voting intentions of people in the country. Now, how do we use that as a group of advocates to say it has to stay as a whole of government issue post the pandemic? The other one is, and we had a great meeting at our summit a couple of weeks ago, we had 4 National Cancer Institute directors. They work directly for the governments in 4 different countries. And they were asked the question, do you believe as a result of the pandemic that more funds per GDP, percentage of GDP, will be allocated to health in the future? Apart from one that said, I think we need to become more efficient, which I thought was a political answer. The other 3 said, yes, without doubt. Now, this is our opportunity because we're not going to develop universal health coverage unless we see a massive increase in investment in health. And when you see great countries like India spending less than 2% of GDP on health, they will never get to UHC on that sort of level. So until we push that dial up, and I think we have an opportunity, we're not going to get the UHC that we all deserve. And I'll conclude there.
Thank you, Carl. Thank you. So thank you so much, actually, for sharing, about your organization and the learnings and the challenges that we heard through pandemic. I'm aware of the time. I want to keep the last 10, 15 minutes for questions from the audience. But one question. I guess, going back to universal health coverage, we all are talking the same thing. We said, promoting healthcare, quality healthcare, adequate healthcare with adequate, forces, healthcare forces, ethics, preparedness, integrated healthcare, cancer treatment, among other treatments, and public health, as Bettina said, is a business for all. So universal healthcare is really a business for all. And, I think what I want to really know is, despite having countries and politics and many things playing role in this, how can we as NGOs today collaborate, reshape this to make it really happen? This is what I would like to know. We start with Bettina.
Thank you. I was the one saying that we're all into it. Howard was the one providing figures. There is, if he allows, one figure I would like to add. The healthcare workforce worldwide is 80% female. And I think we have to be all in it, not only the females, all of us. I am a trained MD pathologist, but I also am a historian. Every big crisis has made changes in society. The Black Death occurred in Europe, killing half of the European population, and at the long run, this changed completely the society. Why? Because the serfs became a workforce that was suddenly to be paid. And instead of having a two-class society with aristocrats and serfs doing the bad work, now they had to be paid. This turned out to be a three-class society with people in the middle, bourgeois, citizens, and at the long run changed European history with revolutions and so forth. If this COVID would be able to tell us that the 80% of health professionals doing the work, or as the UN meeting in 2019 said, health is done by women and directed by men, could change, and also change the fact that of the care and cure work, over 90% is unpaid. If these kind of serves could become a real place in society, I think that would be already a very important shift. And I think that all my colleagues here from the NGOs are in it together to say, we want to collaborate, we want to put health in the right place, and we will not be able to do it if care, cure, and cleaning work is the serf's work that is not really regarded. And I think, and I hope I have your support for that we are going to put health at this level where even 80% of health workers and nurses are men. Thank you.
Thank you, Bettina. Oliver?
So the question about collaboration, I think some of our organizations are already collaborating to some extent, some more intensively, some more loosely. And I think even though some of the organizations here at the table represent a very large number of members, I think we're still small organizations to an extent that we represent large number of professionals, but our capacity itself is rather limited in terms of the staff we have, the resources we have, and maybe the competences that we have in our own organizations. Our network, the International Network of Health Promoting Hospitals and Health Services, we have 600 members worldwide, but in fact our secretariat is very, very small. We have a very small team, and we work with our governance board members and General Assembly to implement the strategies that we stand for. So I think at the content level we can agree on a lot of things that was said. I think we just need to make specific plans. We need to fill them with life and come up with action plans. So what can we do within 1 year, working together as the organizations sitting here around the table, rather than having wordy statements where we all agree on the importance of gender equality, nursing needs, and all that. So I think I very much appreciate it. Maybe under the IHF, who brought us together here, we can take this step forward and see what we can do together, very specifically as organizations, to tackle the issues that we have mentioned and that we all agree on today.
Thank you. Otmar?
Well, I'm a little bit skeptical whether just the cooperation is the important part here. What we have seen over the past 2 years is to a large extent a failure of politics. We have seen politicians who were neglecting the pandemic. We have seen politicians who were lying about the pandemic. We have seen politicians who used the pandemics to advance their own fate in that system. And I'm not quite sure whether just cooperating between NGOs is enough of that. I think what we need is we need much more listening of politicians to NGOs and to civil society, which they currently don't do. And as you have seen during the UN meetings in last month, Mr. Bennett said, well, when it comes to pandemic, I know better than the medical professionals. Well, maybe. I have my doubts. And I think the last 2 years have proven actually the opposite. So what we do and when we cooperate, I think it must be very much, and following up what Cary said, must be our advocacy work towards politics to bring up change towards universal health coverage, to bring up change for better preparedness and better reaction, but also to bring up more objective decisions during a pandemic. And I mean, you all know the presidents of some big countries which really have produced a mess instead of helping to cope with the pandemic. And some of the problems have been pointed out here very clearly. I think Howard has excellently shown the staffing problem that we have. It's most severe with nursing. We have the same problem with physicians to a lesser extent, but certainly it is existing in there. We have a very strong challenge to the quality of the workplaces in healthcare, which have to be improved, which is not going on. And yes, we have to cooperate, but it is probably more important that we get political change. And that may be something which we have to direct to in order to be better heard, to have a better means for our health systems. And I'm not only talking to curative care, I'm also speaking about the public health, which has shown a lot of deficits over the past 2 years in many, many countries of this world. So yes, the cooperation is good, is necessary. We certainly can do more. But actually, let's be realistic, it is political change that is necessary, and that has to come through our elected representatives, or those who are leading the countries if they are not elected, which makes it even more difficult. But that is something which we have to look for and advocate for. Thank you.
Thank you, Howard. Thank you, Otmar. Howard, please.
Yeah, I think we need to be bolder and to go further, because we're all agreed on the health case. But I think what the pandemic and what I think climate change is doing, and I think that we should be rallying much more strongly on climate change as well. Nurses who I talk to, say you're worried about COVID, climate change. You ain't seen nothing yet. But what the public has seen through COVID, and they're seeing through climate change, is the intimate relationship between health well-being and your health status and your economic well-being. The economies are tanking or struggling. They're seeing the impact on our personal lives, our family lives, the separation, reinforcing the things that are important to us. They're seeing they're seeing the risks to peace, to safety, to security within our communities as well. So I think that this experience with the pandemic, and as I said, I think it's going to be jet fueled with climate change as well, takes it beyond just this, health is nice to have, but it's integral to the sort of world that we want for ourselves and for future generations to come. And as Otmar says, at the same time, we have seen political leaders really struggle with a global approach, with a multilateral approach, because understandably they've got national interests that are right in the forefront of their, of their minds, but they also struggle with the fact that they don't have the levels of trust. Think of us again. We are blessed at the moment with quite a lot of trust and public support, and we're showing that we're also, it's not always easy to come together in a multilateral cooperative way, but we have ways in which we can do that as well. So it's very difficult, because I have to be very careful about in terms of saying become more political, but I think there is a vacuum and a space, and I think we are a natural group of partners and people who can come forward and provide some bolder leadership in that space. And the other thing that I would say that I think that we do need to do, though, continue to do, is to hold feet to the fire. Terrible analogy, given I just talked about climate change. I mentioned about climate change, I guess. But in terms of the evidence that we can bring forward. So just give you just two examples on this. We brought some work forward with WHO just a few weeks ago that Otmar and I were involved in. Estimate that there's 115,000 health workers who've died as a result of the pandemic. That's a conservative estimate. I think the figure is more nearer to 250,000. But this is the statistic which worried me even more. That 115,000 is based on work technical people at WHO with some of our support have done. The number of health workers that countries have actually reported to WHO who have died, less than 7,000. Less than 7,000. We see this, with the vaccine issue as well. Only 10% of health workers in the continent of Africa who've been fully vaccinated. I think that we have a really important role as well to bring forward the best evidence that we can about the reality that our people, the people we represent, and the people who are receiving care from our people, what they are experiencing as well.
Thank you. Neve?
So I think it's really important to recognise that not all NGOs are created equal either. I think if we ignore that reality, I think we can talk as much as we like about cooperation and collaboration, but there are some NGOs are bigger than others. Also, they might have a set of interests that are not always aligned with all other NGOs. So we have to start in every collaboration that we have as an organisation with a discussion around shared values and shared vision. And I think that's really important. But I think in this context and in this agenda particularly, and I would echo Howard's comments about climate change, if you'd asked Greenpeace 30 years ago whether they saw themselves as being such a huge influencer of climate, people's response to the climate change, they would probably have laughed at you. So none of us can know the impact that we are potentially going to have in the future. I do think also we need to be better as organisations, and I think many at this table already are, but the multiplicity of NGOs out there working with organisations like WHO, who really are powerful, do have the political influence that many of us as individual organisations can have, and only when we come together with that shared vision, a shared set of values, and universal healthcare is a great starting point for that, can we really have the influence that we all want to have.
Thank you so much. Cary Adams?
Well, I agree with what's been said. In answer to the specific question, though, what can we do? I think we do have our own interests, let's be absolutely clear, and we're structured around those common interests within cancer or nursing or whatever it may be. So I think from the pandemic, there's a couple of things which I think are important that we have to do individually. The first one is to make sure that we capture the learning of going through this pandemic and make sure that our community and the patients, cancer patients, and the treatment and the screening, we are able to inform rapidly any pandemic response from governments to ensure that we protect the interests of cancer patients and or whoever those patients are, the interest group that we have. We have an NGO responsibility to do that. The second thing I think that we're looking at, and I think we have to take very seriously, is, and it was mentioned earlier about the innovative ways in which some organisations, some countries have used new technology, Zoom, oh God, I'm fed up with Zoom, but Zoom and all those sort of things, telemedicines, etc., to re-engineer the way in which we can approach some of the classical, been doing for decades, ways in which we deal with patients, the way we educate, the way we support and things like that. And I think we need to capture those and make sure that those best practices are shared around the world, and that's the role of an NGO like my own to make sure that happens. When it comes to common ground, I'll reiterate what I said earlier, and we are not going to get to the beauty of UHC, which I think we all aspire to, and it's just absolutely the right thing we should be doing, without serious investment from governments in health, the health of their nation. And so that's a common ground area which I think is important, that we do use this to leverage the advocacy messaging consistently across the NGOs, that we believe collectively that unless there is a significant uplift in the availability of funding for national as well as for development assistance across low and middle income countries, where many countries rely up to 30% of their health spend is provided by third-party countries, I think we're going to struggle to really address some of the major issues we're facing in the future. Over and above pandemics, NCDs are going to grow a massive problem around the world in the next 20, 30 years. Now, what do we do? Because as that grows, we need more nurses, we need more research, we need more safety, all of this falls together. So I think that's a collective response that we can have, and empowering WHO is something which I think others have questioned. I agree. I think WHO are critical to the way in which this world addresses global health in the future. And I think the climate change needs a similar body of response, and that they should be coordinating their activities so that we make decisions personally, collectively, and also at a government level which support addressing climate change and health implications in the future. The final point, we haven't covered it here, but the role of the private sector in all of this is absolutely critical. And I do fear that sometimes from a health perspective, we don't engage the private sector as much as we should do in order to get them to do the right things which help global health in the future. And so I would just put that down. I think the private sector should have some form of accountability in terms of addressing many of the challenges that we're facing now.
Thank you very much. Karsten?
Well, it is kind of difficult to find something new to say after so many excellent statements. Nevertheless, I would say that one of the reasons for collaboration is that we bring together different types of organizations, different types of competences, different types of ways of doing things. Obviously, to achieve the change we want to achieve, political action is necessary, and it is naive to believe that if you just provide the right knowledge, then things will happen by themselves. That's not the way the world works. Nevertheless, it is still necessary to build the way we develop politics, healthcare systems, to build it on a solid knowledge base. And I see our role as a contributor to that, with the clear intention that knowledge should not remain in a closed network, but should be made available not only to other researchers but to practitioners everywhere. And we might also have to consider how do we make knowledge available to politicians in a way that's understandable to them, and that they can see a way to translate the knowledge into action. Knowledge into action translation is one of the things that I think is really important, and that we would like to contribute to. And I agree, by the way, that the WHO is a very important actor in this game, and an actor that we should interact with as much as we can.
Thank you. Thank you very much for your responses. I think I want to open the floor to questions, either virtual or from the audience. No question okay.
Hi, can you hear me? Yes. So I wanted to thank you all for this panel. It's quite excellent to hear about this idea of partnerships and how you're looking at the deal of impact of COVID over UHC. There's one particular topic that I wanted to hear a little bit more, maybe, Howard started touching it, but I wanted maybe if you could expand and we can have more of your ideas on it, is the issue of trust. Because the whole COVID response had to deal a lot about the way we communicate about the health response, about the way we define activities, the way that we are accepted and received by communities, and the effectiveness of that proposed health response, right? And then that touches not only the way we would share the knowledge, as Dr. Angel just said, but also the way we build up the health professionals to be able to do this kind of activities, the way that we create policies for eventual also misleading or unethical, this is a bit of a gray zone, but activities coming from health workers maybe, you know, that are not completely in line on those principles that we believe of science, you know, of evidence-based decision making. So I wanted to hear more from you, from the NGOs. What is the perspective of building trust, creating effective communication, and moving forward towards UHC in this complex scenario?
Anyone can answer? Howard or Ottomar?
Sorry, if I can just start from the point of view of building trust. I think at the foundation we would say that collaboration, genuine collaboration with communities when you are designing and delivering services. We've been talking about person-centered care, and I don't know about anybody else in this room, but I'm tired of hearing that being used fairly in an empty and rather meaningless way. I think at the foundation we push very hard in all of our work for the voices of people as partners in care and communities to be heard at every point in that process. And I think the pandemic has shown how little that has happened, and that fundamentally has to change.
Please.
Yeah, I don't see that this current move which we have in building trust by being as liberal as possible doesn't work. That is quite obviously. Now for 1.5 years there have been these attempts of telling people, informing people, hoping that they will follow, and quite obviously that is something that has not worked. What has worked is rather to concentrate on obligations which we commonly have and individually, and which we have to serve. So it's probably a very Kantian approach, but I think that is something that everybody, but also our politicians, have to deliver this obedience of obligations which we commonly have in order to be trustworthy and to build trust. What they now do, just talking about it and saying, oh, you can do what you want, and that produces trust, is not the way it works. Trust is something that has to be earned. It's very difficult to be built. It's very easy to be lost. And unfortunately, we have lost a lot, and it will take a long time to rebuild, but it will be only rebuilt by really serving obligations, common obligations, which we have to society, individually and commonly.
Thank you. Please.
So just briefly, because I mentioned on the trust issue, consistently polls from Ipsos, Mori, all of the polls around the world, doctors, nurses at the top of those polls. Where does that trust come from? That could be a session all in itself. But one of the things I would highlight is that the professions work to a code of ethics. We've just revised our code of ethics from ICM, which we've used in many countries around the world. Non-discrimination, respect for the individual, advocacy for human rights, promotion of health equity. That's the ethical foundations. There are others of the profession, and I believe is related intimately to that level of trust. We've seen the problems that we've had with vaccine take-up because people don't believe and trust the message, and our people, our healthcare workers, then suffer the consequences of that. We've had examples of nurses being attacked verbally and physically, abused by the anti-vax movement. But that does not mean that the health professionals then come forward and say, governments, give us the message and we'll go and communicate that for you. No, I think we have a big role in terms of public health advice and information, but we will communicate that as a profession. And there's a tension there, because that's really risky for governments to say we're going to hand over the messaging. They're not. So there's a lot of work to do on that. And then just one issue, which just one very practical issue, because when I turn on the TV and if I see political leaders, who do you most often see stood beside them? Often there will be the chief medical officer, and they should be there. Often there will be the chief scientist, and often they are men as well. We've only got about half the countries in the world who have a chief nursing officer. The prominence and the positions for the leaders of all of the healthcare professions does be seen more visibly advising governments, but also in all of our health system as well. I think those are some very important practical steps that we need to take.
Bettina, thank you.
Thank you very much for your question, and I share completely with Ottmar and Howard have said. I think there's another thing that we have to learn and that we have seen we're not so good during COVID. We need the discussion between science and politics. And both sides, I think, scientists and politicians, haven't been the best to understand the other's point of view. I think that it's a big learning now on both sides, as we all agree that health is a political issue, and if we want to go forward, we have to learn how to communicate at that level. Howard said, yes, there is the chief medical officer, but I have seen in some countries they tried to communicate, but it didn't turn out. One and the other, science or politics, didn't got the point. And we have to see that during this is going on, there are a lot of forces that want to split us because it's for their own political gains and so forth. So I think also that listening to what you said, the real voices of people, is something we are learning in our democracies. And with new forms of democracy, more digitalized democracy, we will be able, I think, to listen to real people and then give real answers. But these are developments that we will see to come now, I think. Thank you so much. Thank you for International Hospital Federation to put these interesting people in one room.
Karsten, I think you have a feedback?
Yeah.
Thank you.
Okay. Well, first, I agree with Bettina that there is a lack of understanding, mutual understanding between politicians and scientists, and it goes both ways. And if we are sitting on the scientist side, then we can only change our own way of doing it. We cannot hope to directly change the politicians. We can't influence them. We must find ways to do it. And then back to the question of trust. I am a physician myself, so I understand very well that some of the trust is deserved by the confidence in professionals working according to professional standards for the people they serve. But I also would refer to Niam that it's not enough anymore that we work for people. We should also work with people, involve them in what we're doing, asking them questions like, what matters to you, both when it comes to individual treatment and individual treatment plans, but also when it comes to the way in which we design and run our healthcare systems. And that's an important issue for the future, to finding ways of doing that.
Thank you. Please.
Yeah, I think I've broadened the issue of trust to be the relationship between the scientists and the evidence and the data and the media as well. I think the old style of evidence going into a journal, published, peer-reviewed, talking to the government about the evidence, I think that still has a role, but I feel that what the COVID has revealed, particularly now in our community, is that we've been overrun by the social media and the new media responses, which is 24-hour news items and fill it with anything, and often very emotive, often very bad news, because that goes 10 times further and lasts 10 times longer than the good stuff. And who wants to see the boring evidence and what actually works when you can read about all the stuff that's going wrong by government. So I think the relationship between science researchers, the global public health community personified by Geneva University, maybe we need to be a little better at understanding where people find their truth from. I was staggered to hear, am I allowed to mention Harry and Meghan? Is that allowed? But when I hear that someone says, I have my truth, this is my truth, and I'm not too sure what that means, because it's usually based on nothing, but it seems to be endemic across a community now that if you believe something, it is a truth. And that is counter to the scientific movement over the last 200-300 years, that nothing is a truth unless it's proven beyond doubt and peer-reviewed. So I think the relationship between scientists and the media is going to be critical in the coming years, and we should probably balance our attention both on governments and media and how we use it to best effect to get the truth out there.
Yes, please.
I don't want to comment on the truth. I think we discussed it from many different points of view. We have only 4 minutes left. I want to state that, unfortunately, I think a member of the International Alliance of Patient Organization was invited but couldn't attend. I think that voice was missing today. I also feel another voice is missing, which is the voice of the future generation. I'm working a lot with physicians, students associations, with younger people. And if I were to summarize the discussion from this panel to them, they would say, yes, that's nice, we agree. What are the next steps? I think younger people are very clear about that time is running.
Yeah.
Now, I agree we need a political framework and all that, so we can come back in 5 years and 10 years and say the same thing. But what will be the next steps coming out of this panel for the next year? What can we do? And I took something away. I've learned something new from the panel members, some of which I wasn't aware of, and especially the work of the organizations. We have developed new standards for health promotion in hospitals and health service. So I will approach each of you to see some connectivity between what we are doing in our standards and how it links into your work. So that's something I can give to you and to the audience, to the panel, in terms of very concrete steps and action coming out of this panel.
Amazing. Thank you. Yes.
Just a response. The next generation is perfectly involved in this because they have to pay for all of our mistakes.
Thank you. That's so true. So we're only 2.5 minutes. Okay. Well, we'll have a quick response to that question. Yes, please.
Sure. Salim Hasham. I run a healthcare management company. So interest of time, I'll keep it very short. I think one of the areas you all talked about is chief executives, management teams really have to navigate all these issues you talked about. Integration, politics, we talked about retention. I'd be interested in your thoughts. I mean, I certainly have a clear idea in my mind about the role of leadership. But do you have any perspective from your standpoint in terms of how COVID has impacted leadership? Has the leadership styles actually changed? Because the complexity and the level of integration that's really needed is different. So I know we're limited for time, but any particular thoughts that you have in terms of impact on leadership?
Anyone? You want to start?
Okay, I'm going to give that a shot. I think to the point I was making earlier, I think COVID has pushed leaders to collaborate more. I think, though, there's still a long way to go on that. So to go back to the continuum of networking, right through to collaboration at the other end, and if collaboration is the most mature evolution of that, I think we're still a long way away from that. And I think it's about power, and it's about resource power quite often in systems. We're talking about systems that are financially constrained. I think underlying a lot of what people have said today is the fact that we have underinvested in health and care for a long time. So people, organizations, leaders are at pains to hold on to the resources that they have so painstakingly gathered, sharing that, collaborating genuinely for common benefit is a big ask. So I think that's where the political leadership comes in.
Bettina?
A very short one. I think, yes, we will even see more changes in leadership, because what we see worldwide is people are stepping out of their jobs, not only of the health jobs. They're stepping out of jobs. So if you have less people willing to do work, you will have to create new forms of leadership. It's a pressure that comes, and we will see in the consequences, I think, step by step.
Just very briefly, I absolutely do see a shift from the purely metric focus, not as important as they are, to the relationship piece, and I think that's, and I do see some of that taking place. But I think this issue about always being concerned about your organisation. I think a lot of our health systems, you need some good incentives to get people to collaborate, even with the best will in the world and the best intention. What incentives do you build into your health system to make sure that acute community social care, the different parts of the health system, are working together?
Thank you. I would like to add to that actually more women leadership. Thank you so much. It brings us to the end of our session. I would like to thank all our speakers. Thank you, Bettina, Oliver, Neve, Howard, Ottomar, Karsten, and Cary, for an interesting session. I think this could have gone on and on and on without end. Thank you. And thanks for the IHF team, Ron, Dr. Risto, Sarah, for making this possible. Thank you all.